First off, thank you very much for joining. We've got a great panel today who are going to present on the different components of inclusive health and caring for children with intellectual disabilities. To take a look at the learning objectives for today, we will define inclusive health and wellness and recognize its foundation in children's rights and health equities. Utilize policy and partnerships to achieve health outcomes for persons with disabilities, identify health disparities and challenges, describe strategies to assure meaningful inclusion of children with intellectual disabilities and care in the pediatric medical home, and understand resources available through partners. And the next one. Our presenters today, we have David Ellsworth. He is from the Ohio Department of Health, and I will allow him to introduce himself when he presents. Dr. James Duffy with us from Dayton Children's Hospital, Mark Barnheiser with the Down Syndrome Association of Central Ohio, and then I'll kind of close out the afternoon. So this will be 1 hour, but we look forward to having you join in. If at any point you have a question, you are more than welcome to put it in the chat box in the webinar setting, or you, of course, can speak up on the phone. So with that, I will pass it over to David.
Hi, everyone. My name is David Ellsworth. I'm the Policy Specialist for the Ohio Disability and Health Program. Today we're going to be talking about inclusive health and the implications that has for improving the patient experience. The Ohio Disability and Health Program is a CDC grant-funded program that broadly aims to improve the health of all Ohioans with disabilities, including children, for partnership with the Ohio State University Niswonger Center, the Ohio Department of Health, the University Center for Excellence in Developmental Disability in Cincinnati, and the Ohio Government Resource Center. I wanted to start by giving a bit of disability history. I think that this is pretty interesting. For most of the 19th century, disability was really viewed as something to be avoided, and that hadn't always been the case. There's some pretty notable examples of young children receiving care even in ancient times when resources would have been scarce, and that would have been very difficult for the community to do. Nevertheless, that was a valued part of the human experience. But a couple things happened in the 19th century where the perception towards disability turned. The first was Reformation. So the concept that we could reform individuals and change them. It was disability could be reformed through education and some sort of confinement. We could change what disability meant. The other advent that occurred around this time was the concept of germ theory, that we could treat a whole bunch of diseases, and thus we could treat disabilities as well. So that's when the perception began to shift. Disability was something to be avoided, it was kept out of the public eye, and it was something that we could cure people of. It was really thought of as a burden. You can see here, this is Rockland County Hospital. It's set up much like reformatories or prisons were, and it's something that we could treat. And this way of thinking gave rise to the medical model of disability, where the individual or the person or the child is really the center of that problem. Under this traditional view, it's something that you could be cured of. It was kind of the physical manifestation of disability, and it was the person's impairment that we were trying to work on. The person that was impaired, and they are kind of at the heart of the problem. And we know that this isn't necessarily the case. Impairments and chronic illness often pose difficulties for our children with disability, but most of the time they are not the main health problem. This isn't to say that the medical model doesn't have its utilities. I think that some aspects of this model are very useful. It generally provides us with some guidelines for handling problems and predicting outcomes surrounding a person's disability. We can use the medical model to ensure that people with disabilities can have healthy, active lifestyles and make some dietary changes if necessary. It ensures access to treatment for chronic diseases, and we can use it to minimize the impact of co-occurring or secondary conditions for children with disabilities as they arise. Another interesting part of history was the disability rights movement, and in many ways this paralleled the civil rights movement. In fact, many of the same people were involved in both movements. And this is depicting a sit-in in San Francisco that was one of the largest, and this actually was advocating for the rights in Section 504 that reduced discrimination for people with disabilities and eventually led to the Americans with Disabilities Act, which expanded on those rights, ensuring equal access to clinical services, for example, for persons with disabilities. And around this time, this gave rise to the social model of disability, where this places emphasis that it's really the societal barriers around us that cause impairment and really add to or cause disability. So things such as inaccessible buildings can cause disability or augment disability. People's attitudes or perceptions towards people with disabilities can be very disabling themselves and lead to worse health conditions. And that organizations themselves could be disabling. They might be too inflexible. The procedures, the care that we are providing might be inflexible, and that causes disability rather than just the person's impairment. So the World Health Organization goes on to say that disability, thus, is not just a health problem. It's a very complex phenomenon reflecting the interaction between features of a person's body and the features of the society in which he or she lives. Overcoming these difficulties faced by people with disabilities requires interventions to remove these environmental and societal barriers. I think that that's worth focusing on. Disability, it affects 61 million people, or adults rather, in the United States. It's between 1 in 5 or 1 in 4 individuals. So if you look around the room or your practice, you can see that 1 in 4 individuals is a substantial part of the population. And if you're not planning around the needs of people with disability, you really are missing a very large portion of the population that you serve. In Ohio, 16% of children has some form of disability, and this is just the statistic of, I believe it was 0 to 7. So that's less. You can tell that that tends to increase with age, but it's still a very significant portion of the population that has some form of disability. In fact, when you consider this as a demographic, which we like to do, it's actually America's largest minority demographic. And it's interesting that this is the only one that you can move in and out of. So you might acquire a disability later in life, or you might be born with it. And it overlaps with other demographic factors, age, race, sex, etc., that can all impact health in various ways. We also know that people with disabilities are subject to health disparities, again, largely kind of arising from those societal barriers that we've discussed. In adulthood, they're much more likely to be obese compared to people without disabilities. They're much more likely to smoke. In fact, they're twice as likely. And Ohio is no exception. In fact, we have one of the largest disparities in smoking among people with disabilities compared to those without in the state. Much more likely to have heart disease and diabetes, as well as some mental health concerns as well surrounding depression, suicide ideology and attempts, and other risk factors relating to behavioral health. So here's our definition of inclusive health, and it's actually a relatively simple one. Inclusive health means that people with disabilities are able to take full advantage of the same health programs and clinical services available to people who do not have disabilities, and that we should offer the best care possible to the growing population of people with disabilities. People with disabilities have the same health needs and health concerns as non-disabled people. Some of the misperceptions surrounding providing care to children and people with disabilities is that that's a different specialty, or that different physicians are taking care of those patients, and that's simply not true. true. They access the same community resources that everyone else does. They might experience a narrow margin of health, and this doesn't necessarily relate to their disability. This might be related to poverty, social exclusion, and other secondary conditions such as pressure sores, urinary tract infections, etc., that are occurring along with their disability. And evidence suggests that people with disabilities face barriers accessing the health and rehabilitation services that they need in many settings. And this has been very well documented in the literature. So I think that we'll talk about this later today as well, but there are a couple things that we can do to provide excellent care to patients with disabilities, including children with disabilities. The first is to break down attitudinal barriers, and those might be the implicit biases that we have, those that we aren't even aware of towards people with disabilities that affect how we provide care for them. Another kind of damaging thing that we tend to do is make assumptions on behalf of people with disability, such as that they're not able to understand what we're saying. A big one that we should try to avoid is, and a fairly common one, that people with disabilities and children and adolescents with disabilities are asexual, and that's simply not the case, and that can cause some very poor health outcomes surrounding sexuality and unplanned pregnancy, etc. We should focus on communication, both communicating with the patient and allowing extra time for communication. Sometimes we may need to repeat back. And I know that we're talking about children in these settings, but this is a good time to, again, practice talking with the patient. The caregiver or parent will chime in as necessary, but it's a good time to begin to communicate with the patient as well. Providing reasonable accommodations. This might be adjustments to timing. It might be a wheelchair accessible scale. It might be an accessible exam table. Providing quality care is really the goal throughout. And some other things that you can do are offering similar trainings, the one we're providing today, to staff, and adjusting timing as necessary, providing a little more time for office visits. Inclusive health can improve lives. We know that disability itself is not poor health. People with disability can lead very productive, very happy lives. Access to clinical services benefit everyone, so those that are able to accommodate a range of disabilities really benefit everyone that you're trying to serve. And we have the power to improve the health of everyone through inclusion in our practices. So a couple best practices that I've noted is that budgeting for inclusion is important. You might need to budget for things such as a Hoyer lift or wheelchair accessible scales, sign language interpreters as needed, and sometimes this falls by the wayside. Use person-first language, as you've heard me use throughout, referring to the person first when we're referring to disabilities, but speaking to the patient. And if they have a different term that they'd like you to use, perhaps they prefer deaf or hard of hearing or blind, just follow their lead. Offer communication in multiple formats when possible. Again, this benefits everyone. Allow extra time for exams and for transportation. A lot of people have difficulty with transportation, and this is really a barrier to our clinical services. I have a link to the ADA guidelines for clinical spaces, so on your own time, feel free to look at those. They have diagrams for what an accessible clinic can look like. And then I've also included an online option for inclusive health training, and that is another option. That is my contact information for this short little intro, and I will turn it over to the next person.
Dr. Duffy, you are up next. So we're very excited to welcome Dr. James Duffy to present. Dr. Duffy, if you could explain some of your areas of expertise and the work you do, that would be great. I am not sure if you can advance your slides, but if you can't, I'm happy to do it on your behalf.
Thank you. I don't think I can advance my slides, so I may just have to talk it through. And that was a great introduction by Mr. Ellsworth, and I'll try not to duplicate the material that he presented, but I'd like to drill down a little bit, talk about some special topics regarding children. I am essentially a developmental pediatrician. I have my personal responsibility right now is to develop and implement a program at Dayton Children's Hospital for children with medical complexity. So some of my thoughts are sort of directed towards the more severe children in this group, but I think what I say will be applicable to all. I'm also the chair of the Medical Advisory Committee for the Bureau for Children with Medical Handicaps with ODH, and so I'm pretty much aware of what services are available for children with disabilities, neurodevelopmental disabilities in particular, in Ohio. So let's move on to the first slide. We've already talked some about, Mr. Ellsworth talked about this as sort of general principles, and what I want to emphasize here is that as we're working through policies and procedures, even within a small office, I think it's helpful to include people with intellectual disabilities in the creation of policies and planning, and this is, in my mind, it assures a full participation. I'll give you a brief anecdote. Dayton Children's recently put together a playground across the street from Dayton Children's, and it was a very nice and very attractive little playground. But then I went to the Parent and Family Advisory Council. I'm the faculty representative to the Family Advisory Council, and one of the first comments was made by a mother who had a child in a wheelchair and said, it's very pretty, but there's nothing that a child in a wheelchair can do. So even in a children's hospital, mistakes can be made if these things, if policies and procedures and services are not in part designed by parents or youth with special needs. Next slide, please. Again, drilling down a little bit for children with intellectual disability. Depending on how you define this, and I think the DSM-5 defines developmental or intellectual developmental disorder or developmental disabilities in a very improved manner. It's not IQ. It's basically defined by functional disability or functional abilities, and I like that. But I think that depending on how you can define this, either broadly or narrowly, children with intellectual disabilities or developmental disabilities are often misdiagnosed, over-medicated, over-treated, and admitted to the hospital. And the problem here, is if you have a child on a gurney who can't defend herself or can't identify what's wrong, who's technology dependent, that child is going to be very intimidating to a primary care doctor or even an emergency department. So children are admitted more often, they're over-treated and misdiagnosed. And I think from a social justice standpoint, we can identify this as an underserved minority population. Now, once again, it's dependent upon definition, as we talked about before. Certainly 17 to 20% of kids are defined as children with some sort of disability, if you include learning disabilities and ADHD and that sort of thing. If you look at the other end of the spectrum, children who are technology dependent, that's really less than 1% of the population. So depending upon somewhere in between, about 5% of the Medicaid population accounts for almost 16% of the Medicaid costs, and that's national rather than local. For this conversation today, I think it's important to realize that there is that adult illnesses start in early childhood. The life course of children with intellectual disability is in many ways no different than other children, in that the origins of lifelong health are in early childhood. And that's sort of confirmed by the fact that children with intellectual disability have an obesity rate of about 33%, and children without ID have an obesity rate of about 17%. So, almost twice the rate of obesity, even with the obesity epidemic. Children with intellectual disability are about twice as susceptible, and that starts in early childhood. But the long-term, the lifelong effects include actually shortened life. There's, I think, don't have on this slide, but somewhere around 18 years difference between a woman, an adult woman with intellectual disability versus a typically developing woman in the United States. And these folks are twice as likely to die before 50. Next slide, please. And Mr. Ellsworth went through the common barriers, and I think I'd like to touch on these and kind of identify some of the particular concerns that we might have as pediatricians. And the first one is attitude. And if you advance the slide again, please. First, examine ourselves. We have many preconceived notions, and I think the first thing that we have to talk about, I think, is that children with intellectual disability may be, well, let me put it this way, that intellectual disability isn't necessarily associated with physical appearance. In fact, many children with intellectual disabilities are typically appearing. And the reverse is also true. Children who have neurodevelopmental problems, who may be dysmorphic, may very well be close to average range of at least receptive communication. So we can't make judgments based on how a person looks or their facial physiognomy, whether or not they are able to understand what we're saying or communicate effectively. And I think it's almost, this is, I think, universal, not just with children with intellectual disabilities, but we as caretakers and as pediatric healthcare workers of any sort, I think it behooves us to think before we see a child and care for a child, what am I assuming about this person that might not be true? And in particular, are there assumptions that I'm making, or preconceived notions based on our cultural training for children with or people with disabilities? How will that affect how I'm able to care for this person? And I'll give you a couple of examples of that in a minute. Moving on to the next slide, please. In this, we've already talked about person-first language. I think that's extremely important, and that applies to all kinds of things. For instance, I try to influence the folks here, residents and the people that haven't thought about this, who often say something like foster children or medically complex children, both of which are dehumanizing. It's children who happen to be in foster care and children who may have technology dependency. And so I think that's something that from the top to bottom in any organization, whether it's a community pediatric practice or it's a social service organization or a pediatric hospital, we need to make sure that the people on the front line, the receptionists, everybody else, is aware of the person-first language and also some of the other cultural kind of preconceived notions or prejudice that we may carry forward into our care of these children. I want to emphasize on this slide that I very strongly encourage people to assume that folks with intellectual disability, particularly youth with intellectual disability, are capable of making their own decisions. Now, obviously, young people or people who are have difficulty with this expressive language may have maybe have difficulty participating actively, but the concept still remains that as long as a child is in or a youth is in the care of a parent, that obviously the parent is in a position to provide consent But the child and the youth in particular still needs to be respected in the ability to provide assent for any particular medication or treatment or intervention that we should design. I haven't included in my topics to talk about today transition, but this transition to adulthood is extremely difficult and should start in pediatric practice, should start that conversation at 12 or 13, because now some children will be able to be self-sufficient at 18, but many children with intellectual disability will not be, and parents and families need to work forward and plan ahead for transition to adulthood, particularly those who have to deal with legal guardianship concerns. Legal guardianship in Ohio generally costs about $1,000, and although much of the guardianship, much of transition has to happen right at the point of turning to 18 or the point of majority, but many of the plans have to be in place long before that, and parents need to know that. Next slide, please. The written material we'll talk about after a little bit at the end of the presentation. The staff at the AAP have put together some beautiful handouts that I think that we've reviewed in terms of mealtime and play time that's consistent with these written material guidelines at no more than a sixth grade level, free of jargon. The last two I'm not so sure about, but it's something to be considered, including images of people with intellectual disabilities and promotional materials, and also other accessible formats like Braille and large type. Next slide, please. We talk a lot about physical obstacles, and I'm not going to go through that, but I think we also need to talk about emotional obstacles, that we need to develop safe spaces for people. And that means that children and families feel respected and welcomed. And in particular, that all staff, not just healthcare workers, but non-clinical workers in the offices, in the reception areas, in the hospitals, are aware of how cultural backgrounds, as Mr. Ellsworth mentioned, or somebody mentioned earlier, I think, before the discussion started, that certain cultural groups have, in fact, cultural groups, let's say it positively, have different ideas about what intellectual disability means, and they will accept certain treatments, or they will not present for treatment, dependent upon how their culture accepts children with disabilities. It's important to understand that, and in particular, understand the perception of how emotional safety is either present or not present. That people can talk about their concerns, their worries, but also feel accepted as total human beings, along with their other abilities. Next slide, please. I'd like to move on here, just talk a little bit about shared decision making, and it's to me this is one of the cutting edges of pediatric care, particularly with children with challenges such as intellectual disability or developmental disabilities. How we have changed our care of families and children to avoid the top-down kind of directive that the doctor says comes to a conclusion, makes a recommendation, and the families follow it. That is not how we're practicing pediatrics these days, and I think that's a great change. Although many pediatricians don't quite know how to engage families. But I think the place to start is that social justice, once again, the health justice perspective, that families and patients have a fundamental right to understand all reasonable options and arguments for and against each option. That's particularly important when we're talking about end-of-life kind of concerns, but not as much end-of-life, but also, for instance, technology dependence, involvement in activities or services in the community, variety of different things that might be a challenge for parents. And how do we actually involve the parents in shared decision making, and in particular, how do we involve youth with developmental disabilities in designing programs or participating in policy development or making decisions about their own health care. There's no question, though, that shared decision making has been shown to reduce hospital surgical and emergency costs and also lower out-of-pocket expenditure. And I've included a pediatrics article to support that. By the way, my slides are a little bit wordy, but I think that if the slides are available to folks later on, I've used documentation there at the bottom and a lot of links that you can find out more about what I'm talking about. Next slide, please. The components are these. I think most important here is that each decision maker openly expresses opinions and preferences about treatment options, and then the final decision is reached by consensus and mutual agreement. And that means that particularly with complex chronic conditions or non-complex chronic conditions, that parents and youth have an opportunity to work through the options. And there may be a delay in the treatment, or there may be there may be an improvement in the time lapse between presentation of a potential therapy and the actual the therapy application. I'll give you an example of that. We've developed decision aids, written decision aids for parents in our system. For instance, when they're in the NICU or in the hospital, or when they're older and have difficulty with swallowing or digestive disorders, we have decision aid now for parents who are discussing G-tube placement, and it allows parents to understand the options, understand the positives and the potential risks of placing a G-tube. And I think what we're seeing, and we have a quality improvement program in place, we're seeing that parents are experiencing much more comfort with the idea of placing a G-tube earlier on, so that children are able to improve their nutrition earlier in the process rather than wait till their nutrition is in danger. Next slide, please. I'd like to move on just slightly to the idea of relational care coordination. These are care maps of children with medical complexity, and you can see what was discussed before, that the medical part may be only a small part of the care plan. There could be, for instance, Isabella's case on the right. There's some medical stuff in green along there, but look along the right. There's the education. There's advocacy for the parents, other services, insurance concerns, emotional support for the family, and DME, medical equipment. This is the sort of thing that many families are. This is sort of on the extreme, of course, but this is what many families are confronted with in that community. And how do we do that? Well, next slide, please. We do it through what I would be. We do it through a team-based care. We can't do this all as pediatricians. We need other people to participate in this, particularly nurse care coordination and social work, linking services, attention to social determinants. I like to think of this as relational care coordination because of our interest, particularly in our interest in promoting relational health and resilience in early childhood. That care coordination isn't just sort of a medical or technical activity or something that's limited to our electronic health records, but it tends to the quality of relationships and the quality of communication, particularly with home visitors. I'm absolutely convinced that that the success or failure of a home visiting program, even despite the particular guidelines for home visiting, the success or failure is dependent upon the relationship the home visitor develops with the family, and that relationship then extends to the family and the healthcare facility. And what we'd like to believe, and I think that happens, it also can strengthen the resilience of the family, which then strengthens the resilience of the child and the parent-child relationship. Next slide, please. Some of the differences in care coordination model between children and adults, and I'll go down, you can read the one on the left, but I'll also, because the children would encompass all those things along the left, but also along the right, we have to understand that pediatric care coordination changes over time, as was mentioned. At some point, a child might not qualify for a diagnosis of disability, a functional disability, if we can move kids along into a more functional state. But that any kind of care coordination for children has to take into consideration that children live in and dependent upon families, and live in a social network, and live in a community, and live in a state, and live in a financial support environment. And in particular, children, as we all know, are disproportionately poor, with large disparities among subgroups, and that's particularly important for children in a number of groups, and I would include children who are in foster kinship care, children with medical complexities, children in immigrant populations, and children in deep poverty, those who are homeless or in food insecurity. Next slide, please. Just as an example of a team, how difficult the team might be to put together in a community, this is essentially our team in the hospital, and it includes a team lead, and I might mention that teaching residents and medical students how to lead a team is an important task that's new to medical education. How to be the leader of the treatment team, but it includes all these other folks, and I would include. I know we're running out of time already, but what I'd like to do is sort of emphasize a couple of modifications that might be made by these team members, and in particular today we're talking about food and diets and exercise, and I think one of the concerns that we have with children with intellectual disabilities, the increase in the rate of obesity. But what is important to understand is that dietary reference intakes for children with for children in general are based on typical children and typical activity levels, and in general overestimates the requirements for children with intellectual disability. In particular, if you take sort of the extreme again, children that are being fed by G-tubes, for instance, only need about 60% of the usual daily requirements of the energy expenditures. And the rest in energy expenditure, particularly for children with neurodevelopmental disorders, are usually much lower than typical children. And so that the estimates of intake, for instance, the dietary intake, need to be adjusted by weight and not by age. Another thing that you might think about here is that with the child life specialist or the therapist, and in a pediatric situation, if we're advising parents on discipline, one of the important things is that discipline is developmentally appropriate, not chronologically appropriate. For instance, if a child is 10 years old but has sort of an emotional age of 6 to 7, then the parents need to identify interventions that might be more appropriate for a 6 to 7-year-old and apply those, and that would be something that the pediatrician or the healthcare worker might be able to help with. Next slide, please. And I think I'll skip that slide. Let's go on to the next one. Engaging the family is extremely important, even with a small organization, to have a parent, patient, and family advisory counsel, and I've listed a link to a toolkit. I want to mention that the person in the lower right of your slide there is Randy Kleitz, and she was one of the co-chairs of the Parent Advisory Council for Children with Medical Handicaps at ODH, and she has a child that had a bleeding disorder and also developed leukemia, and she just ran for General Assembly and was elected to House District 75 up near Portage County. So it shows how much the families can be involved and how much they can be helpful. The children up on the right both have cystic fibrosis, and that's the Speaker of the House to the right, and to the left is their father. He was also on the Patient and Family Advisory Council. Next slide, and this will be, I think, my last topic. I want to mention that children with intellectual disability are much more likely to be exposed to emotional trauma. And the Ohio study of adults with ID, Julie Gentile performed it. Julie Gentile is the chair of the Department of Psychiatry at Wright State. She's updated these numbers, and so these numbers are a little bit reversed. This is retrospective of folks with intellectual disability who are adults that are participating in a telepsychiatry program. Nearly 50% reported either attempted or actual emotional abuse. 43% reported either physical or sexual abuse. So 40% of adults with intellectual disability in this Ohio sample reported physical or sexual abuse as children. And there, as we know, this is using the classic 10-question ACE survey, but that doesn't even scratch the surface of the other kinds of trauma that are not identified by the ACE questionnaire. And I think that I'll skip the next two. Next one. Okay, and I just want to mention that even small practices may use generic spreadsheets and programs for tracking and developing a patient registry. These are extremely important. As you can see, the registries, as I've listed, are indispensable in tracking diseases, health indicators, social determinants. The best registries actually provide quality improvement support and also information not only on a population level, but something that is on the very individual level, generating reports and alerts and reminders. Next slide, please. And that brings me to almost the end here. The use of technology and telemedicine, particularly for kids who have difficulty with transportation, I think is an area of new developments, and I think that we can move on to the last slide. And a call to action. And I include this as not only the goal is that all children with intellectual disability or all people with intellectual disability have equitable access and full participation, but also that every pediatric healthcare worker should be trained in the care of people with intellectual disabilities and do their best to ensure equitable access to quality health care. That ends my part, and I'll be glad to answer questions either in the discussion period, which I suspect will be pretty short now, but also by email, and that's my email contact information. Thank you very much.
Thank you so much, Dr. Duffy. We will pass it over to our friends with the Down Syndrome Association in Central Ohio, and then we can have some discussion.
I promise I'll move quickly. I'm Marge Barnheiser. I'm the program director for the Down Syndrome Association of Central Ohio, and I'm also a parent of an adult daughter with Down syndrome who's getting ready to move out, and that's giving me great angst. Our association, just very quickly, provides services for families in that central Ohio and kind of southern area, southeast area of Ohio. But there are 5 other associations who provide very similar support services. We've kind of divvied up the state, and so if you happen to be representative of an area that's not in our service area, there are indeed organizations in your area as well. So for kiddos with Down syndrome, there's a lot of physical reasons why they may not be very healthy. About 50% of the kiddos have heart defects, and that impacts their ability to be active and live happy lives, healthy lives. Low muscle tone, hypotonia, celiac disease is big. I would say if we go down the line, sleep apnea, there's a lot of attention being given to that right now because that has a huge impact on their lives in many ways. About 60% of kiddos with Down syndrome have abnormal sleep studies by the age of 3 or 4 already. Vision, hearing loss, 60 to 80% have hearing loss, which greatly impacts what they can do. Feeding issues impact them a great deal. That can cause, challenge their growth, impact their stamina. We're fortunate here in Central Ohio, Nationwide Children's has a very successful feeding clinic that we refer lots of our families to. There are mental health concerns, particularly with the younger group. Undeniable relationship between the mental and physical health in individuals with IDD. The pattern of mental health problems in Down syndrome vary depending on the age and the developmental characteristics of the child. Young and early school-age children who have limitations with language and their communication skills, cognition, they present with increased vulnerabilities in terms of, behaviors, the disruptive and impulsive behaviors. They're anxious. They can be very inflexible. The traditional stubbornness might appear. But those are all really results of the fact that, they often just don't understand what's being asked of them. What they're being asked to do, and they're not being properly prepared to do the activity that they're being asked to do. So if they have deficits in social relatedness, they're self-immersed, repetitive stereotypical behaviors. We'll talk later. Actually, we're having a webinar. We're hosting a webinar with Dr. Patricia Nash on Monday related to the co-occurring diagnosis of Down syndrome and autism. There are some folks who struggle a great deal with making that diagnosis, and she'll talk about how to make that diagnosis and when it can be made. And that's important because those individuals who have autism as well as Down syndrome need those additional supports. Chronic sleep difficulties, again, the sleep apnea is sort of become a real hot topic and has become far more apparent with a higher percentage of our population than we ever dreamed of. So something to look for. With the older school-age children, adolescents, as well as young adults with Down syndrome, as they develop better language and communication skills, cognitive skills, they still exhibit an increased vulnerability to these items, depression and social withdrawnness, diminished interests and coping skills. We note this a lot, especially when individuals are getting ready to leave high school. They've been involved very much in school and have been included in lots of activities and everything, and then find that many of their typical peers, most of their typical peers are leaving, going off to college, and sometimes they are not. While we do see a higher percentage of individuals attending college, there are some wonderful transition programs around for individuals who have IDD. My own daughter was, always included through all of her education, had a wonderful group of friends. And when it got to high school and they were talking about moving away and going off to college, she felt very isolated, Her world was getting so much smaller. So we were fortunate in that we found a college program that she was accepted into, and that turned everything right around, and she was feeling just all better about herself again. So these other issues, again, the chronic sleep difficulties, that is something that they have really put a lot of attention on. It's difficult, as you might imagine, even if sleep apnea is diagnosed, to get individuals to wear the CPAPs and to address their sleep apnea appropriately. So that goes right into our next slide. It's one of the many challenges that involve with caring for a child with IDD. And those challenges obviously vary a great deal depending upon the child's unique needs and health-related issues. As Dr. Duffy mentioned, cultural environment can have a big impact on how the parents care for their child and what kinds of challenges they might find. We've done a lot of work with our cultural outreach lately, and we found that particularly with the Somali population and the Latino population, there's a big mistrust of any kind of organizations, particularly governmental organizations, as you can understand, and that impacts their reaching out to resources that their children need to live a healthy life. Caregivers have to start early. We talked about that. Children with IDD have a tendency to be very routine-driven, and that includes their eating habits and how active they are. So if they develop poor eating habits and when they're very young, it is even more difficult than it would be with a typical child, perhaps, to turn those habits around. Health issues can, of course, impact to what extent the child can participate in social sports. Low-impact activities like walks in the park, things like that are recommended. There can be additional challenges if the individual has digestive system issues, celiac disease, or Hirschsprung's disease. Sometimes that impacts how social the individual can or wants to be. Autism spectrum disorder and Down syndrome are both indicative of a vast array of behavioral consequences. Some, include challenging behaviors that will impact their socialization and their ability to engage in recreational or organizational sports. That can prove, very challenging. For caregivers, they can have a heightened fear of bullying or physical injury to their child with IDD. They may be more protective. They're anxious about the child participating in any kind of physical or social activities. As Dr. Duffy reported, there's a higher incidence of abuse, and so parents are very aware of that and are obviously nervous about that. But unfortunately, that results then in a more sedate and isolated lifestyle for their child, too, if they're overly protective. The last one, the importance of inclusion in school and community, that is just so incredibly important for a child's healthy self-image and developing friendships early on, because those peers will be a big part of their support system when they're in school. So that's something that we emphasize a great deal. DeSaco offers training and support for those who are struggling to have their child included, especially in school. Parents struggle with that a great deal. And one thing that I did not list on there, but Dr. Duffy kind of alluded to it, is that I think one of the additional challenges for caring for a child is for a parent how to handle the misconceptions of either a medical professional or an educator who is still has very low expectations for their child, and that's challenging because you're looking to them to give you guidance and direction, and that can be very challenging to overcome those low expectations and to fight to have those expectations risen. These days, kiddos with Down syndrome are, living independently and getting married, and they're driving cars, and they're going to college, and they're living very normal lives, and that's all due to improved education and improved medical care. So, resources that our organization provides. I see we're almost out of time, so I'm just going to let most of that go. I'll let you read that. There is one program that our organization, we collaborate with Quantum Health, and we provide a program called Care Partner, and that helps families work through issues related to insurance or hospital billings, eligibility for CMS, those kinds of things. So that's a really great program. We have we have a medical outreach program, and that is for the medical community. We work with Lettercase, and those materials we are happy to share with any medical provider, but Lettercase also has them online. You can download them for free at lettercase.org. And with that, I think I'm going to give us a couple minutes.
So now I'd like to kind of introduce the resources that have been developed at Ohio AAP in collaboration with our partners. And so we are very grateful to receive funding from National AAP and the Special Olympics that focus on inclusive health. And so this work has been funded by the Inclusive Health Grant supporting healthy weight for children with intellectual disabilities. And the goal for that really being to take an inclusive health approach to the resources and different projects that are funded. And so with that, we worked to update 3 handouts that were created under another program at Ohio AAP, and that were targeted toward this population, the 7 through 18 population. And so we really strived through engaging experts, those that presented today, but also those that focus in feeding clinics and work with children of intellectual disabilities and children of other physical or cognitive disabilities to incorporate language, visuals, and guidance that are really inclusive of all children. So you can see here we've incorporated a lot more visual components to the handouts. If you would have seen the old ones, they're a little more word heavy. But here we have what we're calling the caregiver corner on the front side, and then the back, or whichever way you choose to present it, is an opportunity for both activity and engagement in nutrition and activity for the children of that age demographic, but also an opportunity to use it as a communication tool. And so, for instance, if a physician would choose to use this in their office, they could ask the child to draw a picture of them cooking in the kitchen and asking them what they would make and what they like to eat and that kind of thing, and then tailoring that nutrition guidance based on that information. or draw a healthy habit that they would like to do that week. And so really engaging the child in what activities they like related to health, nutrition, and play, and engaging in discussion in that way. We included some extra activities just to make it a little more engaging and something that they could do while waiting in the waiting room. But really using visuals and them communicating to the physician or to the healthcare provider what kind of nutrition and physical activities they would engage in. And so as you move through to the next age group, you again see a very similar front page nutrition guidance in the broadest schemes as you get to the older population. Really is similar, really focused on drinking water first when thirsty, engaging in activity 60 minutes a day, and then emphasizing nutrition from all the food groups. And so the front page really focuses, again, on helping parents, serving as those role models, and how to create a food environment that sets up a healthy environment for your child for their food and play. So it talks a little bit about sleep. That is a component of this, but really focused on how to have healthy snacks, healthy dinners, screen time, that sort of thing. As you look to the teens turn, on the back page, you can see it's updated a little bit, but really still looking to engage the child in drawing, identifying what they will do, what they like to do, and using photos and different cues to communicate that. And then here is our 14 to 18, a little bit of a different look to update that to that age group here. And so, but the messaging is really the same. So that guidance to have them drink water first when they're thirsty, engage in activity. We really aim to have the activities and that be applicable to people of all abilities. And so encouraging dancing in its freest form, to encourage taking a walk, going to the park, finding safe space to be active. And so those are the resources available that are new and newly posted on our website. They are available here for printing and will be incorporated into our other programs to be shared. So I'd like to just extend a very sincere thank you to our partners through this process, to AAP and Special Olympics for the funding, of course, but also to the Down Syndrome Association of Central Ohio, to Marge for all of her review of the content, the Ohio Department of Health, a kind of array of staff there that have been great partners for us, David and Ann Connolly at ODH, and then Dr. Duffy, of course. And we've had a couple other medical professionals review to make sure that the nutrition guidance is the most up-to-date possible. So with that, a big thank you, but I do want to open up. I think we've got a couple questions if folks can hang around for an extra minute or two. We got a question through here that while they understand this focuses on pediatrics, what resources would you recommend for parents who have adult children with Down syndrome?
Well, here in Central Ohio, we're fortunate that we have one of the very few adult Down syndrome clinics in the country. It's located at Nysanger Center at the Ohio State University, so that's a wonderful resource. I'd have to say that our own library, we have a big library of materials. Information about everything from behavior to a process of moving out to teaching your child how to transition from into adulthood, all sorts of things like that. Your local Down syndrome organizations would have resources for that as well. We feel like we're going to be putting a lot of effort into working with organizations, with companies, and talking with them about how employable individuals with Down syndrome are, and helping to develop more opportunities for those adults. But we also have an adult conference or a conference every year for adults with Down syndrome. That's held in August, and that's a statewide conference. We open that up to everyone. During that conference, they have numerous information sessions that they can attend and learn from. And then the parents use it as well as a way to get away and regroup and refresh, but also to touch bases with one another and learn some important information. So,
to the individual that asked that question, I sent you back the link to the information to the adult Nighthawk Center. So you should have a link there. Do we have any other questions for Dr. Duffy or for Marge or David? I apologize. A couple people were muted, so if you were asking a question, they might not have heard you. Does anyone have any questions? Okay. If you do have any questions or a more specific question about resources or something, we'll hang on the line for just a minute. Otherwise, thank you so very much for attending today's webinar. We will be posting, or we can send you the slides so that you have the resources. I know Dr. Duffy included a bit more information for that purpose. So we will get you the slides. But thank you so very much, and a huge thanks again to our presenters today for sharing their expertise. Thank you all so very much.
Thank you.
Good job. That was a great.
Is anyone still on the line?